Kenyans.
Yeah.
One of the major things that has changed is that the structure of NHIF was such that it was meant for people with a pay slip. That at the end of the month, there is a deduction that then goes to NHIF to take care of your medical expenses. What is happening right now in the country, out of the total 53 billion Kenyans, only about 1 million are on a payroll. Yes. So what does that mean? That we have a whole lot of close to 50 million Kenyans that are not on a payroll. Do they need health services? Yes, they do. So one of the things that we are having to change is to take care of everyone. Whether you have a pay slip at the end of the month or not, then we need to take care of you. The other thing is that healthcare has changed. Those decades, most of the common diseases were communicable diseases that used to be passed across person to person within the community. As we speak now, the highest number of people that we get to admit to hospitals are due to non-communicable diseases. Most of these non-communicable diseases are diseases that are preventable, are diseases that can be managed early. So that means a change in structure to see how do we identify these non-communicable diseases very early in terms of screening, in terms of promoting good health, to ensure that then we do not have a high number already suffering from NCDs.
So let me just come in there. So all this, nobody's refuting the changes that you've put in place as a ministry. So what was the complexity in ensuring that all that you've talked about is integrated into a system that is already working? Because so far we've seen certain challenges with regards to rolling out this new product that you've come up with. So what was that challenge in ensuring that NHIF proceeds vis-a-vis starting a new one? I
have expressed myself already. One is a structural challenge. When we say that it was largely for payroll, that end month there's somebody who is deducting and paying, and most of the Kenyans now are not on payroll. Of course, how do I change that?
So we couldn't.
It is a structural thing.
We couldn't integrate the others.
That means you have to do something fundamentally different to be able to take care of those who are not on payroll.
All right. All right. Well, let's talk about recent audit report. Of course, we're still on NHIF considering this is a transition, and there were certain issues that were raised in that particular audit report, just seeing how there was misappropriation of funds with regards to NHIF. And I want to pick a specific one because it's at the center of the rollout of this new scheme that you're talking about, and that was the variance in hospital bills versus the claims that were paid out, which stood at 367 million. What basically means these were books that were cooked by officials at NHIF, where we made excessive payments that probably went to the pockets of the people. How are you going to treat this with this new scheme that you're dealing with?
Precisely, and I want to ask Kenyans then to believe us when we say there was something fundamentally wrong with NHIF. How would such a thing happen if the systems were working well, if we had the right people working? That should never have happened in the first place. The fact that it happens, it means there's a big problem. So how do we sort out that problem? One is in identification and licensing of facilities that should provide healthcare. That we must use the existing institutions to ensure that proper audit of facilities is done for them to be enrolled to social health insurance as a service provider. For example, we have had cases where a facility claimed to have done surgeries, yet they do not have a theater. You see? That is fraud completely. So what are we doing now is that what we did in the last year, I think it was around October, we did a census of all health facilities, so that then we know if you say you are a dispensary, if you say you are health, you are at level 3, you are a health center, or you are level 4, you are then you must be having the infrastructure that is needed, the equipment that is needed, and the staff to provide that service. So there are many loopholes that were there within NHIF. Number two is manual interventions in terms of drawing figures. I know you'll bring up the issue even of wrong entries, you know, typing errors.
Typing errors.
Why were those there? You know, those are things that can easily be taken care of if you have a digital system. And that is why Social Health Authority, the SHIF, is 99% digitized. Very few manual interventions will be there. The other thing is identification of patients who are done for surgery and who need to claim. We have had cases in the past where somebody, and I have talked about this before, where you find that one patient, let me use myself as an example, that I go to a facility, I am amputated my right hand at the elbow. Then you get again, I have gone to another hospital for the same surgery, for the same amputation. Yet we know very well that human parts do not grow after it has been cut. You see? Okay. So those loopholes where somebody could claim on behalf of another person, somebody could claim a surgery that has not been done, are the ones that we are trying to seal under social health authority. Okay, you've talked of the aspect of moving away from a manual system and the explanation, which I term as an excuse that was given by those ministry officials, that it was a typing error. And that is why there was that variance in the tune of 400 million. And we have people making errors in the tune of 400 million. You've said you want Kenyans to believe you that this is going to be sorted out with the digital system. But we've often not seen issues again occurring when a fully digitized system is happening. So what is that assurance past your word alone to see to it that we're not going to see such issues happening? One, the system that we are going to roll out is tamper-proof. And we want to ensure that from the point of entry, then there's no manual process anywhere there. That is why we have started from the lowest level of service. If you go to a community health promoter, which is level 1 of service, they have a gadget where you are identified and your details are put in that gadget. We expect that if you go to a facility, first of all, just identification of the patient will be from what has already been captured. If you look at what we are rolling out now in terms of registration, you are doing it on a USSD code, you are doing it on a digital platform. What does that mean? That from the first very level of entry into health service, we are picking information or capturing information digitally. Okay. Number 2, which I need to say that you need to have the right people doing the right job. Yes. So we are going to have a suitability test of the staff within NHIF as we transit them to see that indeed you have the expertise, you have the experience to run the system that we want to run. Well, you've often or not, when you're trying to fix a problem, when you're trying to create a new scheme and come up with a way forward, you do away with the rot that has been in existence. And we've seen these officials in NHIF perpetrate this misappropriation of funds. And just a few weeks ago, the leader of the majority in the National Assembly stood before the House and assured every single employee of NHIF that they wouldn't be fired. The transition into the new scheme, and those that wouldn't fit would be redeployed. So how then do you convince Kenyans that you're really working towards something? Because it seems you're taking 2 steps forward and 20 back. Let me explain. And we are speaking the same language with the leader of majority. We have about 4 mechanisms that we are moving staff from NHIF to Social Health Authority. The first is voluntary retirement. If you feel you have worked enough, we have people who are left with very few years to retirement, then you might say, now that is a digitized system, myself, I'm analog, I opt out. That is number 1. Number 2, we have people with disciplinary cases that are ongoing. Like this thing that you're talking about the misappropriation, the fraud cases and all that. So far, by the way, Kenyans need to know that from this, and remember it's an audit report, so this audit did not happen yesterday. We have had it. We have had the results before. 5 staff were already terminated. 16 staff are under disciplinary and investigation is ongoing. Should it be that these staff are found to be culpable, then they will be going. That is a way of exiting. Number 3, suitability test. Are you fit to move or not to move? Then you are taken to Social Health Authority. What are the grounds of this? If you do not, what are the grounds of this suitability test? If you're fit to move or not? Grounds of suitability test is 1, we have done our human resource instruments for Social Health Authority because we know it is a highly digitized system. We know the processes that are in there. So we have mapped out who are the staff that are needed, what kind of skill is needed, what kind of expertise and experience is needed. So we have a number. We have done our human resource instruments. They have now been forwarded to SCAC and the Public Service Commission for approval. Once they have been approved, then we start recruitment based on those instruments. Okay. All right. And all this is being done by Ministry of Health officials, or you sought
some external help to see to it there's some sort of neutrality and there's no favorism? Because at the end of the day, these are people who've worked there, so there's going to be some sort of favoritism.
By the way, Ministry of Health work is to drive the policy.
Yeah.
Once the law was passed, the Social Health Insurance Act of 2023,
yeah,
we did put in place a board. So Social Health Authority has a board.
Okay.
Besides a board, we put in place, I did gazette, the Transition Committee. Transition Committee is made of experts, yeah, in different fields of practice. We have lawyers, we have finance people, we have operations people, strategy communications, and some of them have been co-opted from the ministries. For example, the person sitting in on HR matters was co-opted from SRC. Right. From Public Service Commission. Okay. These are the people who have then worked on instruments, and I expect neutrality, yeah, from them, because they are not associated to NHIF, neither are they associated to Social, okay, Health Authority, neither the ministry.
All right, speaking on that transition committee, I believe we have what a few Kenyans have had to say about the same. Let's just put that on the screen and quickly go through the same. That is Dr. Eri Mwa. She's a gynecologist, rather. She says this SHIF thing is the biggest scandal in the making. Mark my tweet. We need to reject it and kick the CS of health out. Let's move on to the other tweet. It says, this is lone traveler Yvonne Mobai, says, mind you, MOH's own committee that they set up to advise them on SHIF told them to suspend SHIF's rollout without the regulations issued for SHIF and return to NHIF. They noted that SHIF is poorly thought out and doesn't have adequate infrastructure. Even pilot trials failed. Lastly, of course, just scroll it a bit back. Right there, of course, that is just the same tweet right there. And finally, we can pick this last one. Ferdinand Omondi says, we don't need SHIF. We need you to stop stealing from NHIF. Basically, what we've been talking about right there. But back to the previous tweet before the end one right there. The transition committee that you've talked about, they advised you to stop whatever you were doing and return to NHIF because it wasn't strong enough. But right now, we already see people are already enrolling to the system. So where is that disconnect between the connection of the committee telling you, halt, this is not well thought out through, and you still going ahead?
One, what you're saying is untrue. I have the report, yeah, from the transition committee. We meet regularly with the transition committee and we discuss. Yeah. We have various facets of social health insurance fund that need to be rolled out. Yeah. We have what is ready, what percentage is ready. For example, the module on registration is ready. Yeah. And we have begun registration. Okay. What was not ready is module like for claims management, module for ERP, yeah, other modules that were not ready, and that is what they said, because these modules are not yet ready at 100%, they are still under development. Some are at 60, some 70, some 90%. All right. Then hold off this. Begin with registration, the module that is ready. I have a report, I can share the report with you. All right. There is nowhere where they have said, do not roll over to SHIF. So there was no communication to hold on, see, this process is well thought out before you can move on with anything. That is I am explaining to you, there are different facets of SHIF. So there was that communication. The issue is the communication on what is not ready for rollout. All right, okay, that I believe has been cleared. Let's move to that claims. And I want to respond to the tweet from the guy now. Okay, yeah. Maybe, just maybe, please ask her, I see the photo is of a she, to read, to look at the benefits package that we have put out. To look at the tariffs that we have put out. If she is a gyna who is interested in her patients, especially maternity patients, then she needs to read that. Okay. Because we have a comprehensive maternity package where we are covering delivery, whether normal or cesarean delivery. We are covering postnatal and after after delivery. Yeah. So she needs to interest ourselves. I think, let me encourage Kenyans that I am the carrier of the message. You may not like me as the carrier of the message, but stick to the issue. What is the benefit package that Social Health Authority is offering vis-a-vis what was being offered by NHIF? I'll give you an example. Okay. Delivery, normal delivery. Yeah. Under NHIF, public facilities used to be compensated 5,000 shillings. That was the tariff. Under social health, insurance fund that has been raised from 5,000 to 11,200.
Yeah.
Is that progressive or regressive? Just from you, now that I've given you that information. Is that progressive or regressive?
Well, the argument is when, say, for example, you're talking about the deliveries that you've catered for both cesarean and the natural one. They've said some of the arguments that have arisen is that whatever you're allocating is not even a pinch of what is required, say, for example, in terms of the cesarean. And the whole argument is, why are Kenyans making a contribution to this magnitude and in this amount, in the sense that they cannot necessarily get the full service? I don't know if that is...
I hear you.
Yeah.
I have asked a simple question.
Yeah.
We were paying 5,000 for normal delivery. Under Social Health Authority, that is going to be paid at 11,200. Is that progressive or regressive? We were paying 17,000 shillings for cesarean section under NHIF, and it was being done, and facilities were being compensated. Right now, we have moved that to 32,000 shillings. Is that progressive or regressive? But let me explain something.
Yeah.
The cost of inputs is the same. And we have costed a pair of gloves. If you go and buy a packet of gloves that has 100 pairs of gloves in it, right now, if you go to a chemist outside here or a pharmaceutical farm or whatever shop, you'll buy it at between 350 shillings to 400 shillings. A box that has 100 pairs of gloves. So it doesn't really matter whether that glove is being used in a public facility or it is being used in a private facility. What we are trying to do as the Ministry of Health, that we have costed. The time for the gyna is the same, whether that gyna is practicing in a public or a private facility. The instruments that are required are the same, which we have costed, you see. So we are just trying to be in line with the conversation that is ongoing in terms of accountability, in terms of efficiency.
All right, let's talk about that claims management that you raised earlier on. We've seen officials from KMPDU and medical practitioners have an issue with it, saying, why then are you bringing in a third party in this case, which in the case we're talking about are private insurance companies? The argument is, why not reinvest that money back into the scheme so that it does the business? Why is there this sort of introduction of a third party, which is a private insurance firm, meaning the government will have to go and purchase private schemes for the civil servants and everybody and pay that firm? That is where the disconnect is, especially with the claims management. How do you respond to that?
Now, one is that I think they need to read the regulations properly. It says the authority may outsource claims management. What does may mean? If you do not have internal capacity, then you can outsource a firm that can do claims management. If you look at where we have had most losses in NHIF is on claims. So what do we want? We want a firm that can do it efficiently. As it is now, let me tell you. For example, the the civil servant scheme. For every 100 shillings that NHIF was being paid in premium, it was spending 130 for treatment. What does that mean? A net loss of 30 shillings. What does that mean? Then you have to look for a firm to see, because other insurance companies do not go to that extent. Other insurance companies, if you look at their administrative expenses, you'll find it's nothing more than 5%. And that is exactly what we have put in our regulations. Can we manage our costs? Can we inject in efficiency? Can we inject in skill and expertise and reduce wastage? So
what we're looking at here, right here, is it's a private insurance company. And the argument is, we know, we've lived in this country for a long time. We know the misappropriation of funds and the corruption that runs within these issues pertaining to tenders and purchasing of schemes and all that. So what will you do to ensure that this is not the case? Because that is the biggest fear right there. You're basically creating an avenue for officials who are going to transit into this new authority to basically loot public funds. That is the question they're having.
Let me also correct. I realize there's a lot of misinformation out here. There is no private insurance company that is being outsourced to do claims management. It is a system.
It's a system,
Yes. We are moving into...
And who's the custodian of this system?
Social Health Authority.
Yes.
We are moving into a world where people are using digital system to inject some level of precision into what is done. For example, people are using AI tools to be able to determine even what treatment should be used, and you know, some precision and effectiveness. And that is what we are saying, a claims management system.
Right.
This system owned by Social Health Authority.
Okay, well, let's make some progress even as we wind down on the conversation. The next issue is on the indigents, the vulnerable people, and all that you've said are going to be catered for in this particular scheme that you're talking about. Kenyans want to understand what's the rationale behind compelling jobless Kenyans to be part of a mandatory scheme that clearly many of them have said they do not want to be part of.
You know, let's not wait until one is sick.
Yeah.
Then we start saying this person is jobless.
Yeah.
Therefore, they cannot access. What we want is that every Kenyan should be able to access healthcare, quality healthcare, as and when they need it. Disease does not make an announcement that I will come on a certain date.
Yeah.
No. Emergencies, they don't make announcements that they will come on a certain date. Many years ago, we lived very well. Did we ever know that COVID was going to be with us? We did not know. Did we ever know that we are going to need oxygen? We never knew that actually oxygen can be such a big issue.
Yeah.
So what we are doing is that we want to prepare Kenyans to be able to access quality health service as and when it is needed. If you go to your WhatsApp group, I'm sure you are in either one or two fundraisings for a hospital bill or for funeral. True or false?
True.
True. So why? Is it that those people had jobs and therefore they didn't need assistance? Let's take care of ourselves. Let's prepare to take care of the rainy day.
Let me come in there. These are indigents, vulnerable people, and people from the informal sector who might not have the means to contribute.
And I have a solution to that.
You've said you're going to...
Previously...
I'm coming. CS, you've said the government is going to pay the premiums for these people. Now, when you're looking at this particular act, it uses a fancy term in terms of those who are not going to be able to pay also have the option of access to certain financial products. Scrap off that financial products term. These are basically loans. So the issue that you're talking of right here is you're having vulnerable Kenyans who are unemployed. You're asking them to take a loan for their treatment or for one reason or the other. Then after that, you expect them to pay you back again, I presume, with an interest because it's not free money. That is where this whole bone of contention is. Does it make logical sense to somebody who's literally seated in his living room right there in Kibra right now? Do you think it makes sense to them?
Now, I think we need to distinguish issues. And I really thank you for having me on this. Hopefully Kenyans are listening. One, we have vulnerable persons who do not have any form of income, neither do they have capacity to engage in any economic activity. That means whatever you do to them, they cannot raise money for their insurance. Those people, the government is going to take care of them. We have people even living with disability. We have people who are very old. They cannot fend for themselves. The government is going to take care of those people. It was already taking care of close to 1 million of those indigents. The government has still committed that it is going to pay premiums for those people. We have people who are able to engage in economic activities. We have people already engaging in economic activities. It's just that their income is not consistent on a monthly basis. But once in a while, they go to Mjengo, they get money. Then we are saying, the time that you need to pay for insurance and you do not have money, then we'll make it easy for you to access some income to pay, so that when you get your pay from Mjengo or from wherever it is, then you can be able to pay back, because you are still vulnerable. Whether you are making money or not making money, you are vulnerable to disease. So that is why we need to take care of you. Please distinguish those, that those who can't pay won't pay because they do not have any capacity, then government will take care of them. But we have those who have capacity, but their income is not consistent, is not on a monthly basis, they do not have a payroll. They are business people. Today they are doing booming business. The following day they do not have. We have farmers. This season they are harvesting. The next season they have nothing. So we are just making it easier for those who do not have consistent incomes to be able to borrow when they are not able to. And then once they get their income, they can be able to pay off.
Okay, just a clarification as we pick one phone call right here. I'm trying to understand the government's capacity. We know very well that part of what was the issue with NHIF was delayed capitation from the government, which is supposed to aid majorly into this program. Secondly, your second partners are county governments. County governments, in those very same counties, we have unemployed people, unemployed interns, doctors who do not have jobs. So it's basically a mess. Now, the Ministry of Health have recently suffered a slash in your budget. You requested for, I think, 320B. You didn't get that. You got way lesser than that. So I'm trying to understand your capacity to cater for about 73% of Kenyans, which translates to about 45 to 50 million Kenyans who you are going to support with this vulnerable, and yet you've already spent 5 billion on a system that you've just rolled out and you're still rolling it out. Your budget was slashed. Where did you get
the figure of 5 billion?
That is what has been reported in terms of the system. I'm just using the figures that have been reported. You're here, clarify that for us. So I'm trying to understand the capacity. Does it really make sense?
It does make sense. The cost of disease is much more expensive than that.
Yeah.
Remember, the people on government subsidy are not even identified by the Ministry of Health. We have the Ministry of Social Protection that works together with county governments to identify who really qualifies for social protection. Now, regarding budget, and let me say this, out of a lot of whatever, the budget was cut. It is likely even to drop further. Does that mean that then we don't provide healthcare? It
just seems a bit ambitious.
It is ambitious.
So that's what you're trying.
And therefore, we have to
Are you setting up yourself for failure?
Not exactly. We have to work together with Kenyans to raise resources. I think our problem has been healthcare financing. For example, the internship issue. If we were able to collect enough money, we should be able to pay for those interns because they are providing services at health facilities. And if the services are being paid for, we should generate enough money to buy equipment, pay interns, and make infrastructure or whatever it is that we need to provide healthcare. So health financing, that discussion, it must be had. Okay,
CS, let's pick one call right here, because in terms of achieving whatever you want to achieve with this scheme, personnel plays a very important and critical aspect to it, and people who are going to work on this. And on the call, I have Peterson Wachira, who's the national chair of KUKO. Let's just hear his concern right here. He says they've been on strike for 94 days. You've not even reached out to them. Peterson, in just under 1 minute, what would you like to communicate to the CS?
Yeah, thank you. Thanks a lot, Alan, and thanks for this opportunity to be able to also weigh in on what is happening. Let me say that the first question I would like to ask is, I saw the CS say that they are going to extend the civil servant scheme, the medical scheme, for another 2 months. And I think the civil servants are actually worried and concerned. If I had already exhausted my scheme, does it mean for the next 2 months it's a continuity of what was there and I have to use out of pocket?
Okay.
Having said that, the other part is that, and as you have said, it's true that you have been on strike for 94 days today. Actually, the CS has not met us, and as clinical officers, we feel that actually the CS has neglected us. We started this strike as 3 unions. The 2 unions, ourselves and the lab, the CS has never taken an opportunity to even sit with us and understand our issues and why this strike is probably taking longer than it should have.
Okay, let's.
I don't know if the CS knows that actually the legal advisors in her ministry have actually been the problem. That's why we have not been able to enter into a return to work agreement, because they keep on lying to the team that it is illegal to enter into a return to work agreement. Actually, there are 2 sets of orders from the court that have directed us to be able to sit.
Peterson, let's give the CS time to respond to those issues you've done right now. Madam CS, in under 1 minute there on my neck. Just probably give him a response to the 2 issues in just under that minute.
Thank you, Peterson Wachira. I think you ought to have also acknowledged that you and I have talked regarding the strike. But having said that, number one is about the civil servant scheme.
Yeah.
This is normally the premium is paid by the Ministry of Public Service. And actually the extension is not for 2 months, but for 3 months. So they are going to pay new premiums. So public servants don't need to worry. Their scheme is going to be extended for another 3 months. Hopefully that after that, then there'll be a proper mechanism of how they access healthcare, besides accessing what would be available under Social Health Insurance Fund. Number two, on the clinical officer strike, you know, we have a department that deals with health professionals. And Wachira will confirm to you, they have sat with the principal secretary. Principal secretary is a very senior government official. That is like my principal deputy in terms of resolving this issue. So I am briefed when they meet. And they have had several meetings. It's just that they have been told you need to have done 1, 2, 3 for us to be able to work on the things that you want. The other issue that has been very difficult is that because the clinical officers want their risk allowance to be increased from 3,000 shillings to 15,000 shillings. Under the circumstances that we are in, and Kenyans are asking, why are you people adding yourselves things? Can you reduce? You know? So under the circumstances, then we are in a very difficult place, but we have put in their request to National Treasury. If National Treasury and SRC agrees on their request, we have absolutely no reason to have that risk allowance increased.
Madam CS, thank you for making time for us this evening. I believe you've gotten some clarification on the issues surrounding the SHIF and the SHA. As time continues by, we'll be having these conversations just to get more clarity on the same. And the CS says, even in as much as you might have an issue with her as a person, give the chance a process and give that process a chance. Basically, let's deal with the issues and not her as a personality. I'm Alan Owino. Our sign language interpreter for this session has been Clement Muli. Do have yourselves a lovely one.